Welcome to ATCM, the Emergency Medicine channel.
Yeah.
A 45-year-old lady presented to the ER with complaints of heaviness of the chest and palpitation since 2 hours.
Okay.
On our initial 10-second assessment, the patient was conscious and oriented. Coming to primary survey, airway was patent, no pooling of secretions, no gurgling. Coming to breathing, respiratory rate of 25 per minute, saturation of 96% in room air. Coming to circulation, at this point the patient was connected to a defibrillator showing a narrow QRS tachycardia with regular RR interval. We asked for a 12-lead ECG at this point of time. The BP was 90 by 50 millimeters of mercury. 2 large bore IV cannulas were inserted at this point of time. Coming to disability, GCS of 15 by 15, moving all 4 limbs. Coming to exposure, temperature of 99.2 degree Fahrenheit and GRBS of 140 milligram per deciliter. Coming to adjuncts of primary survey, a 12-lead ECG was taken which showed a narrow QRS complex tachycardia with a rate of 200 per minute with regular RR interval and P wave falling just outside the QRS complex.
Okay. So just wait. We have a 45-year-old female who had presented to the ED with history of chest discomfort
And
palpitation. So here itself, it has come to know that the patient is unstable. So with the history itself, there is an ongoing chest pain and there is a tachycardia with the palpitation history, possibly tachycardia. So as soon as the patient had come, we have done the primary survey, ABCD assessment. Hemodynamically, she was borderline, 90 by 50 BP. So with this itself, she's fitting into the criteria of an unstable tachycardia. So whenever you see an unstable tachycardia, the next option, what you need to do is cardioversion, synchronized cardioversion. So that is the option. So that is very clear what needed to be done for her. So it is synchronized cardioversion is the treatment. So how will you approach any tachycardias in the ED?
So tachycardias can be basically divided into narrow QRS tachycardia and wide QRS tachycardia.
Most importantly, for an ED physician, our first criteria should be stable or unstable. Tachycardia, you have to remember that usually when you see any heart rate above 150, it is usually not sinus tachycardia. Some pathology is there. Usually if it is sinus tachycardia, usually it will be less than 150. Some books says 140, but usually less than 150. So that is first thing. So whenever you see any tachycardia, our primary aim is to see whether the patient is stable or unstable. So what are the signs when you say that the patient is unstable?
5 signs are there. One is hypotension.
Okay.
Altered mental status.
Altered mental status.
Signs of shock.
Signs of shock.
Acute heart failure features.
Acute heart failure features.
And ischemic chest discomfort.
Ischemic chest discomfort features. So these are the 5 things that you need to remember. So when our aim is that to understand whether this tachycardia is causing any decrease in the organ perfusion, resulting in patients having symptoms. So that is altered sensorium. Hypotension, because of poor cardiac output, there is hypotension. Again, ischemic chest pain, cardiac failure, and any other signs of shock. So these are the things that we need to see. And here she had chest discomfort. So that itself is giving an idea that this patient is having an unstable tachycardia. Then only the next question comes whether it is a narrow QRS tachycardia or whether it is a wide QRS tachycardia. But whatever be the tachycardia, if it is unstable, our treatment is synchronized cardioversion. Whether it is narrow QRS regular, narrow QRS irregular, or a wide QRS tachycardia, our treatment is here is synchronized cardioversion. Will you get a wide QRS irregular tachycardia? Can you get a wide QRS irregular tachycardia? That is my question.
Yes, a wide QRS.
How will you get a wide QRS? What are the reasons for a wide QRS? We are discussing narrow QRS, let it be there. What are the reasons for a wide QRS tachycardia?
Most common wide QRS is VT, sir.
Okay.
Then,
so the most common one is VT, as you said.
Then slightly wide QRS, that is 0.12 to 0.16 seconds, can be SVT with bundle branch block, sir.
So any bundle branch block, LBV, RBV, or any other accessory pathway, whenever you have, you can have a wide QRS. So why there is a wide QRS forming? My question is why there is a wide QRS in the ECG?
Initiation is from the ventricle.
Initiation is from the ventricle. So you have to know the normal thing, that is from the SA node, an impulse is getting generated. That is passing to the AV node. From AV node to the bundle of his, and both the ventricles are simultaneously stimulated and both the ventricles are contracting simultaneously. So that is a normal physiology that is happening, and you are getting a normal QRS. Less than 3 or within 3 small squares, you are getting a normal QRS. So what is happening in a ventricular tachycardia? Imagine that there is a scar in one of the myocardium. There is an left ventricular scar. So from the scar, an impulse is getting generated, and that impulse is overriding the impulse that is getting generated from the SA node. As a result, you are getting a ventricular tachycardia. So whenever one ventricle is stimulated and the next ventricle is stimulated, you will get a white QRS. So in a VT, what is happening? Either from the left ventricle or it is from the right ventricle. So when you have an LV outflow tract VT, that is otherwise called as LVOT VT, you will have an RBB morphology. Whenever you have an RVOT VT, you have an LBB morphology for your ECG. So that is the thing that you can differentiate. Where is the location of the ventricular tachycardia? So one impulse is getting generated from the left ventricle. That impulse is getting passed on to the right ventricle. As a result, you are getting a white QRS. So the time taken for the impulse to travel from one ventricle to other ventricle is what it is having the white QRS. So there is no SA node transmission. So that's why we are not getting any P waves or anything in the ECG for a ventricular tachycardia. But as you said, one of the features of VT is what is called as AV dissociation. Whenever you are seeing an AV dissociation, why there is an AV dissociation? There is an impulse generating from the ventricles. Already there is another impulse getting generated from the SA node. Sometimes that impulse also will get transmitted into this. As a result, in between in the ventricular tachycardia, you will be able to see a P wave here and there. So that is one thing. Then what will happen? One beat is coming from the SA node. One beat is getting generated from the VT area also. So both these waves get fused together to get a fused beat. So that is fusion beats. Sometimes what will happen, that impulse is getting generated from there will get transmitted throughout. That is called as capture beats. So that is how you are getting a capture beat, a fusion beat, and an AV dissociation in ventricular tachycardia. So white QRS, this concept you need to be very clear. Whenever you see a white QRS, one ventricle is stimulated first, followed by stimulating the next ventricle. Same thing happening in your right bundle branch block, left bundle branch block and all. So left bundle is blocked, so right ventricle is activated, and from that impulse is transmitting to the left ventricle. So similarly for the LBV also. So that is what you need to remember. So whenever you have a sinus tachycardia with a bundle branch block, you can have a white QRS. So you need to differentiate whether it is a VT or whether it is an sinus tachycardia with an bundle branch block or SVT with a bundle branch block. So that is the differentiation what we need to make it now. Since it's a narrow QRS tachycardia for this patient, we are happy. But otherwise what we need to differentiate is whenever you see a white QRS tachycardia irregular, that was my question. Can you get a white complex irregular tachycardia? Can you get yes atrial fibrillation with a bundle branch block? You can get a white, but usually when you say irregular white complex tachycardia, it is ventricular fibrillation that you will see only in cardiac arrest. You will not see in this patient. So whenever you are seeing an irregular white complex tachycardia in such a patient, it will be probably an atrial fibrillation with a bundle branch block or maybe an aberrant conduction pathway. So that is what you need to remember. When you are seeing ventricular fibrillation, you will see only in cardiac arrest. So in a nutshell, what you need to understand is that as an ED physician, our aim is to differentiate whether the patient is stable or unstable. If the patient is stable, it is a straightaway thing. You need to go ahead with synchronized cardioversion. So, synchronized cardioversion. So, that is what you need to do. So, how will you proceed for synchronized cardioversion? What are the steps involved in a synchronized cardioversion? Can you explain to me?
So, first we need to take the consent. We need to connect the defibrillator.
Okay.
We need to explain the procedure to the patient. Then we have to give proper sedation. Benzodiazepine opioid has to be given.
Okay.
Then whether it is regular or irregular, we have to adjust the joules. If it is regular, we will go with 50 to 100. If it is irregular, 150 to 200. Then we need to take the two paddles at proper locations and we used to keep it for around 5 to 10 seconds.
So the most important thing, you have to press the synchronize button. So that is the most important thing. See, the people will, what is the most important? You said 5 to 10 seconds, that is correct. Because the machine needed to identify. Suppose it's an irregular or regular, whatever be this, the machine should identify the peaking of the R wave and it should recognize that and it should be delivering the shock at that point. What will happen if you are not pressing the synchronized button? What will happen if you are not pressing the synchronize button? You're just going and delivering the shock.
It can lead to again VT if it's
It can again, it might be the time the heart is in the refractory phase. So suddenly you're giving a stimulation, it can go into ventricular tachycardia. So the peaking of the R wave exactly where you need to deliver the shock. So that is why the most important thing is that when you do the synchronized cardioversion, you just take the paddles, just shock and come out, it will not deliver sometimes. So you have to make sure that the shock is delivered. So you need to keep a couple of seconds more. Then only that shock will be delivered. Otherwise, that shock will not get delivered. So most important thing, as you said, you need to take a consent. You need to explain the procedure to the patient. Adequate sedation. So that is more important. And if you have a paddles which can be adhesive paddles which can be attached to the patient chest, it is much more easier for us to deliver the shock rather than we taking in and placing it, because that is a time where the contact can be poor. The shock delivery might get interferences and all. If you can get the same like our AED paddle attached to that, it is much more easier for us to give the shock. Imagine that this patient was unstable. So it's a straightforward thing. We have to go ahead with synchronized cardioversion. So 50 to 100 joules that you can start off with, and you can see how the patient is responding. The patient is not responding. What will you do?
We can double the dose.
We can double the dose.
Cardioversion.
Still fails. What do you need to do? What are the other options that you have?
We will try three times. We will double the dose and we will try, and still it fails. We have to go with anti-arrhythmic drugs like
You can still, after 2 shocks, it's failed. Like you are given 100 joules, 200 joules, it's failed. You can always give amiodarone. Amiodarone, you can try with amiodarone whether the rate is coming down or not. So that is regarding your unstable tachycardias. Whatever be the tachycardias, whether it is AF, whether it is new onset AF, anything different?
new onset AF we can wait, sir.
Okay. Other things we need to definitely go ahead, and why new onset AF, we need to rule out an LV thrombus, and we need to make sure that otherwise after the shock there can be an event of stroke which can happen to the patient. Rest all unstable tachycardias, you go ahead with this protocol. So now let's see, the same patient was stable. She never had any chest pain. She never had any hypotension. So how will you approach this patient at that point of time?
Initially, we can try, if the patient is stable, we can try the vagal maneuvers. Valsalva maneuver and ice pack can be tried.
Okay. One is Valsalva maneuver. There are a lot of modified Valsalva maneuvers these days. They are asking patient to do a Valsalva, then they are making the patient suddenly lie down and lift the leg, and suddenly there are a lot of modified techniques that has been used these days. And the most commonly used one is the carotid sinus massage. Rule out and carotid bruit and do a carotid sinus massage. And if it fails, very rarely carotid sinus massage, maybe 10% of the time it will be effective. If it fails, go ahead with the pharmacotherapy. The drug of choice will be adenosine. There are 2 guidelines. So when you are going for the European guidelines, it is 6 mg, 12 mg and 18 mg. But when you are going the American guideline, it's in 6 and 12. That's it. So there are 2 guidelines, whichever exam that you are going to prepare. European Council, they tell to go ahead with 3, but here only 2 doses as per the AHA guidelines. 6 and 12. If it fails, what to be done?
If it fails, we can go to other drugs.
Under anti-arrhythmic agents like amiodarone you can try, or even metoprolol or diltiazem, or any of these agents you can try, or else you can even try for an synchronized cardioversion. If it fails, if the medical therapy all fails, you can still go ahead with a synchronized cardioversion. So that is your unstable narrow complex tachycardia. See, then finally we need to see why she is developing this. So that is a question always we need to have an answer. So majority of the time you won't get any answer, but you won't see. There is no reason for an SVT to develop. She need to be evaluated to look for any structural heart disease. Maybe a detailed Holter study is needed to see why she is developing all those type of arrhythmia, and also electrolytes. All the important electrolytes, potassium, magnesium, calcium, need to be evaluated and see for any hypo or hyperkalemia. Then what was done for her?
The patient was evaluated. We have given the synchronized cardioversion and it was reverted. Then we go for a cardiology opinion and patient was admitted in CCU.
Okay.
And further evaluation was done, Holter echo, everything came out to be normal. And the patient was discharged on the 3rd day.
Only one other thing is that we need to look for a thyroid dysfunction also. Hyperthyroidism is one thing which we can easily miss. So hyperthyroidism, always whenever you see an unexplained tachycardia, you are not getting any answer, you have to go for hyperthyroidism evaluation also. What are the precautions that you will take while giving adenosine?
We have to rule out COPD and bronchial asthma.
Is it a definitive contraindication? COPD and asthma? it's a relative contraindication only. It's not a definitive contraindication. And other important thing, if the patient has got a center line,
Half the
half the dose is only required. Next important thing, what are the drugs that can have interactions with adenosine? Theophylline and dipyridamole. These are the two agents that you need to remember. Theophylline is a drug which they commonly use for bronchial asthma. So theophylline and dipyridamole is an antiplatelet agent but hardly used these days. So dipyridamole and theophylline is the two agents that can cause interactions. And half-life of adenosine is very small, so you need to flush rapidly. 10 seconds is only the half-life. So whatever the drug that is needed to reach out, it should reach within 10 seconds. So that is regarding your adenosine. Amiodarone, if it is fails, amiodarone. But if adenosine is not available, you can use any rate limiting agents. If it is an SVT, you can use any rate limiting agents, metoprolol, diltiazem, or any of these agents can be done. So basically, to conclude this, our aim will be stable or unstable. Unstable, you go ahead with the synchronized cardioversion. If it is stable, you have time. So you can evaluate whether you can sit over the ECG and say whether it is SVT or VT with aberrancy wide. All those things you can do. You can look for all those criteria, whether it is a wide Q or a skewed to RS nadir distance. What is the distance? What is the axis? Whether you are seeing any AV dissociation, fusion beat, capture beat, or all those things you can see, and you can go ahead with and say that it is VT with aberrancy, or you can say it is SVT. Not VT with aberrancy, it is VT. You can say it is SVT with aberrancy, and all those things you can do. But remember that usually VT, what it says that they will present unstable, but it's not that the case. They can come in stable conditions also. You will see a patient stable VT without any hypotension, without any chest discomfort, heart rate fixed at like 160, 170. The patient is conscious oriented, talking to you. That also can happen. So previously it was like all white complex tachycardia, it is VT, they will be unstable. But VT stable also can happen. So VT, whenever you see, you can have stable VT, you can have unstable VT, you can have VT in cardiac arrest, that is pulseless ventricular tachycardia. So that is your VT presentation. And morphologically also you can have different types of VT. You can have monomorphic VT and polymorphic VT. Monomorphic VT is what we commonly see. Polymorphic VT is otherwise called as Torsades pointers, where magnesium sulfate is the drug of choice. Anything else that you need to add on? Okay. Anything else, Jerry? Nothing. Okay. Fine. Thank you.